All right, moving on. This is going to be our experts presentation, and we have some fabulous speakers here today. And once again, feel free to put your questions in chat. Our first speaker is Dr. Nirav Shah, and he is a distinguished nephrologist and a professor at the University of Pittsburgh School of Medicine, where he has played a pivotal role in transplant and general nephrology since 2005. He has a career spanning over 2 decades, and he has held leadership positions, including serving on the Pennsylvania Chronic Disease Advisory Committee and the UPMC UPP Board of Directors. His contributions to kidney disease management and research and medical education earned him numerous accolades, including recognition as one of Pittsburgh's best doctors. Dr. Shah, please take it away and enlighten us on your information that you have for all of us out here listening. Thank you.
Perfect. I think I'm having a little technical difficulties. Are you guys able to see me? Perfect.
Yes.
All right, I'm going to share my screen here as well. Share. Are you able to see the screen?
Yes, we are. It looks very good.
Okay. Well, thank you. I'm currently working at the hospital and there's a firewall where I am, so it may cut in and out, but I see we're running a little bit behind. I can try to speed things up a little bit as well. But I've been here for about 25 years at UPMC. I did my training, my fellowship. I was in private practice for about a year and I came back to do transplant, mostly because I found it to be really rewarding. In my training, I think the two best times of people's time in the hospital, really, when they feel happier, is when they leave the hospital after a birth of a child. It's a very kind of a great moment. Also, after a kidney transplant, because it changed their lives in so many ways. And I really missed this in my training, so I came back to do mostly transplant work at Presby. I spend half my time with dialysis population, so I can really kind of speak to both sides of the aisle here in terms of how well people do with a transplant versus staying on dialysis. So Bobby had asked me to speak about a couple things during this talk, and there are three topics that she wanted me to cover. Those were medications, kind of viral infections, testing, and what a sleeping kidney is. I mean, we can talk forever, but to kind of distill these three questions, I prepared some slides, and I'm going to go ahead and just put these on while I talk. Perfect. And so this is going to be the overview of the talk just for the next 10, 15 minutes. As everybody's aware, but it just may not drive home the point. I just wanted to drive it home a little further, is how much people do better when you have a functioning kidney transplant versus staying on dialysis. People in this graph, this is from many years ago, but it just shows the mortality. Both being on dialysis and the colors may not translate well because it is a black and white slide. But the top line is survival and mortality when you have a functioning kidney transplant. And the other lines below that are ones that are on peritoneal dialysis, hemodialysis, and all comers. So it just really to kind of let you know that people live better and live longer with a functioning kidney transplant. The second thing, and there is a little recovery time from a surgery, as with any other major surgeries. The perioperative in the first short time, there are higher risk of complications, and until you reach a break-even point. And we tend to watch people after transplant a little bit more often during this first time to kind of help kind of try to prevent some of the side effects and complications of transplant. But once you reach the break-even point, you tend to, on average, live better and longer. Dialysis without going is not a very fun process. It's tied to a machine for 4 hours, 3 times a week, 12 hours a day, versus peritoneal dialysis where you do it at home every night. People don't feel well after this. They feel very tired. When you do dialysis, you only replace about maybe 15 to 20% of your kidney function. So you're just living with a lot of chronic kidney disease despite having dialysis, which takes so much time out of your day. It's difficult work. It takes time to recover. And what we've noticed is there's some studies where people are just really just don't feel well. They would say almost 100% of dialysis patients are depressed at some form or another, and it's understandable because of all the limitations and how well it works um, and limits to that. And for that reason, and for many other reasons, the goal of every person in the whole ESRD population is to get people to transplant. Some kidney disease is reversible if it's caught early enough, but not most of it. Most of it is a chronic, slowly progressive kind of thing. But the reversible processes are important and try to reverse those. And if not, then if you know that you're going to ultimately end up on dialysis, how do you prevent that? And one of the best ways is to get a kidney transplant in time. People do better if you get a transplant preemptively or before even starting dialysis. Um, some people don't have that option because most of the time, as we've heard from Sherry and the other speakers, is the lack of living donation and the fact that we have such a long wait time for getting a transplant. In some parts of the country, the wait time can be 8 to 10 years. In Pittsburgh, I would say it's about maybe 4 or 5 years. And there's a lot of other things that may make it longer based on your blood type, based on how sensitized you are. But yeah, that's the average wait time we tell people. So back in 72, Congress had passed a coverage act to cover patients for dialysis. And this is quite a big thing. If you look through the history books, they had somebody get dialysis within the Congress. And during on the floor of the Senate, they actually did perform dialysis to show how what the process is and how it can save someone's life. So prior to this, there was no way. Pretty much anytime you had kidney failure, you ended up dying. And so there was a lot of work through the years, and now patients were able to live a life with dialysis, but it just was so expensive that many people couldn't afford it. And so Congress had passed in 72 to have universal coverage through extension of Medicare to help cover the costs associated with dialysis. It was so expensive. I remember hearing stories about death panels where you had to be approved and you had to be presented to somebody to see if you would be able to be covered by this expensive therapy. And prior to this, after this, now it is universal coverage. There are some limitations in this as well, but a majority of it is covered by Medicare. And initially, their plan was to maybe cover about 11,000 Americans. You know, that was their kind of goal, and the initial price tag was $130 million. This is back in 72, so it is more when you account it for inflation. But now this has ballooned up to about 100 billion with a B, not with an M, and there's more than 300,000 patients. So some of the success is patients were able to live a lot and live longer, but at the same time, it is a big burden. So that's another reason to do transplant. It is a cheaper method. It's a better method. People are able to be more productive and they feel better. So not only are you living longer, but you're also feeling better with the kidney transplant. And that's kind of the background. This is just some graphs just looking at how expensive the ESRD population cost is really going up. And I think now some of the more recent estimates are it's over $100 billion. And just to drive home the effect of transplant, everybody benefits. So even the young child at the bottom on the x-axis is the age of people. On the y-axis is how many extra years they get from a transplant versus staying on dialysis. So the red line is just your regular average person with dialysis. And depending on your age, you can live longer or shorter. But even someone who's a teenager, you know, on average on dialysis will only live 15 to 20 years when things are going well on dialysis. And it seems very bleak. No wonder why everyone's so depressed. Versus the general population, the blue line. So you can see how much short their life is cut short by developing kidney disease, either through something genetic, which they have no control over, or environmental factors or medications, diabetes and hypertension being the most common causes. But many times people really don't have a lot of control on getting kidney disease. And so this is one reason why everybody's so depressed. One way to kind of lift that curve instead of being at the very dismal red line is to get a transplant. And as you can see, every age group benefits, even people at 75 to 80 years old, and they would benefit from a transplant. I just wanted to focus on that age category because the way the allocation is and expected life years and how much other disease burden they have, many of them don't qualify. At our center, we don't limit people based on age alone, but it's the likelihood of getting a transplant and getting a living donor becomes more important, especially if the wait year is going to be 5 years, right? So not only are you going to be a certain level of sickness when you get evaluated, if you look 5 years from now, you're going to be 5 years sicker if you're on dialysis of not getting the optimal therapy because, it just doesn't provide 100% kidney function. So as you get older, actually at every age, the living donor benefits are much better than waiting for deceased donors. Just a little bit with cost, and I give this talk to my trainees. On dialysis, on average, it can cost $100,000 to $130,000 a year, and it really doesn't make people feel well. So it's enough to keep them alive, but the goal should be the bridge to getting the transplant, or even avoiding it altogether. Once you get a kidney transplant, there's a little higher cost up front, but going forward, it is a much better modality, both in terms of how you feel, how long you live, and cost to society. So it's a cost savings procedure. In fact, there are a lot of executive orders signed in, and this is during his first kind of 4 years, and he expanded it. And it seems to be bipartisan support. Everybody knows that we need to get more people transplanted. And how do we get this to happen? And he signed a lot of executive orders to help with this process. To kind of look at other things. We heard about wearable or implantable kidneys, and how do you kind of reduce discard rates? I know there's some questions on all this, and this is kind of the whole goal. How do you really get more people to a transplant, and what are the barriers in place? And I don't think it's quite known, but I think there's definitely barriers in place. For example, I know insurance for a while only covered 3 years of Medicare insurance, and then afterwards, the coverage kind of dropped coverage, and patients were losing kidneys because they were not able to get these medicines. And now they're are able to extend that a little bit, but there's so many barriers to this. And I think in a group like this is a good way to kind of get this awareness out there, and how do we get people to really help make changes. And I'm glad we're able to have some of the politicians on board, because it takes everybody's approach to solve this problem. By now, we probably know about what transplant is, but in real, it's pretty much just putting a kidney in and just three major connections. You connect one to the artery, one to the vein, and one to the bladder, to where the urine is kind of produced and excreted from the body. The old kidneys are on the back of someone's body. The new transplant's in the front, as you can see on this. And in technicality, the surgical process is a simple, straightforward process, but there are a lot of complexities, because your body does recognize this as a foreign organ, and it's not yours, and it's constantly going to try to fight it off. And that kind of leads me to my next talk is the medication. So one way we get the kidney to prevent rejecting the kidney is to add medications to reduce the immune system, so it doesn't really fight off something that's not associated with the body. And these are some of the medications that we use. There's even more so than this. And when you get started on transplant, you could be on 10 to 12 new medicines. Eventually, with time, these do get weaned down and down. And some people are only on a couple. It all depends on how your body responds and the course. But the kind of the biggest medications are the immunosuppression medicines. And the two ones that we use a lot are the Cellcept and Myfortic, and tacrolimus. And then these other ones are kind of infection medicines, so antiviral medicine, antibacterial medicines. And these are all kind of meant to kind of reduce kind of the side effects of medicines, because it lowers your immune system, but it kind of does increase your risk of infections. And these are some of the costs, and these are just kind of, I think many of these have become generic, so these are even more so cheaper now as well. I think Bobby had wanted me to talk about some of the side effects, and there's a million of them, and you can get overwhelmed by what you see and read out there. A lot of them are kind of manageable, and sometimes when you know about them and look for them, you can also find alternatives. So I wouldn't say everybody gets the side effects, but if they're intolerable side effects to some medicines, we can easily switch those to other ones. One of the big side effects is skin cancer, and that's something we don't really have a solution, although we do recommend very aggressive skin cancer screening afterwards. And there are some medicines that have a lower risk of skin cancer. So if that's an option, we sometimes can choose another medicine that reduces that risk of skin cancer as well. The other thing Bobby had wanted me to mention was this viral infections. And so especially now, we're seeing a lot of viral infections in the hospital and in the community. And what's our kind of approach to this? Some of these are kind of transplant-related viral infections, so they don't affect people who are not immunosuppressed as much. But when you're on immunosuppression, you can have more complications related. Most common influenza, right? It goes without knowing. But now many people are reluctant to get immunized, and some of these viral infections are preventable or at least mitigated through vaccines. And we're seeing a lot of people not get vaccinated, and we're seeing a big upsurge and a lot of the complications to this. influenza, as you're aware. Cytomegalovirus is another thing that may not affect patients who are not immunosuppressed, but can cause you to be really sick if you are a transplant recipient. Epstein-Barr virus, it's like the mono. So in general, most people are exposed by it, during childhood. If you have protective antibodies, it's great. But if you don't have protected antibodies or you're young and you get an organ that has positive virus, you could get this infection. And sometimes that getting the infection can increase your risk for other things, including certain types of lymphoma. So the goal is to try to get as many vaccinations as you can prior to transplant. Some have vaccines and some don't. And the other take-home message is you want to avoid live vaccines after the kidney transplant. And some of these you only can get before transplant because they only have a live version. Some of these don't have vaccines. Parvovirus is another one that doesn't have a vaccine. It's a pediatric kind of infection. People get the slap cheeks, but it can cause severe anemia afterwards. Coronavirus, which goes without saying. And we're seeing another outbreak of norovirus now. So this is another community thing. Lastly, RSV does have a vaccine available, so we do recommend it for our transplant recipients. But without getting in too much detail, I wanted to kind of briefly touch base with vaccines, the importance of getting vaccinations. Certain vaccines, such as hepatitis B, if you get immunized and you're protected against Hep B, then it expands your donor pool. So you're able to get organs that are also from hepatitis B positive organs, and you have protective antibody. So for all these reasons, vaccination is very important. This kind of just is a busy slide, just separating what's live and what's not live. Many of the providers may know about what's live and what's not live, but I like to empower the patients as well. Every now and then, MMR, mumps, measles, and rubella, is not something you can receive after a transplant because it's a live vaccine. But it's important to get this before you get transplanted, especially now that we're seeing many patients not getting vaccinated. It is going to create outbreaks for people who aren't vaccinated. So just the take-home message. But this is one of something called a JC virus that I had recently seen, and this caused a severe fatal process where the virus attacked the brain. I just wanted to give you the picture that, hey, this is a real thing that we shouldn't take lightly, and try to get your vaccines as much as you can. Kind of testing post-operatively. I think Bobby wanted me to discuss some of this. There's routine blood testing. Usually get tested, every couple times a week for the first month, then weekly. And then once things are stable after the first year, many people just get blood testing once a year. The screening becomes very important, both for infections. Dermatology becomes very important because your risk of skin cancer is dramatically increased. And then all the age-appropriate cancer screening that you should be getting, you want to get. Remember, your immune system fights off cancer. Periodically, they'll do imaging, and then the coordination of care as well. I just kind of wanted to kind of leave some time for questions. But I think this whole bridge to getting people off dialysis also means getting people to be organ donors. In other countries around the world, people are a consented organ donor unless you opt out. In this country, you have to sign in and remember to be an organ donor, and that's put on your card. So just different ways. We do have a low rate of people that are becoming organ donors, and one approach that other places have said is, hey, everyone should be a positive donor unless you want to opt out, and still give the people a choice in this process. But I think there is a little bit of inertia and lack of process, and people just takes too much effort to get people on the list. But that's a societal question as well. So I didn't want to bring up an answer, just to give you some points for thoughts. But I have two daughters, and they always ask me this question, why is this the way it is? And I say it's a big question, and it's a deeper question, and I just a thought. But I wanted to try to kind of leave some time. And Bobby, should I stop at this point and answer questions later?
Yes, we're going to do the questions